Okay, good afternoon, everybody. Nice to see so many people joining us for this last, fifth, but very special masterclass. I'm very honored, we're very honored that Professor Francoise Barré-Sinoussi is here as a Nobel Prize laureate to give this masterclass to you. What we shall do is, I will give a short introduction from someone who started here in 1981 as a medical student and my journey through HIV as a medical doctor in training. Thereafter, Rob Grutes will introduce Professor Francoise Barré-Sinoussi to you, and then Professor Francoise Barré-Sinoussi will give her masterclass lecture for you. So we aim that her lecture will take about 1 hour. If there are questions in between, you can ask them. And after that 1 hour, there's ample time for discussions, interactions, questions, etc. Everything you wanted to ask Professor Francoise Barré-Sinoussi, anything you can think of. So that having said, we want to kick off. So now I hope, yeah, okay. So I started here as a medical student in 1981. And this is just how it looked a long time ago, and it looks very different at the moment. And in 1983, we had a medical microbiology course from Professor Mazurel from the virology department. And he was talking about this strange disease, AIDS, in young people, mainly homosexual people, people from Haiti perhaps, and perhaps a virus, a new virus, a retrovirus being involved in the cause of the disease. So as a medical student, third year at that moment, you say, oh, that's interesting, but okay, you go on with your life. And that's what I did, because in 1984, I did a research elective in Cameroon for 6 months. And as we know now, Cameroon probably is the birthplace of HIV, at least of some of the HIV strains circulating around the world. At that moment, it was a very rural site. And really in the hospital at that moment, to my knowledge, at least as I can recall, there were not so many patients really with AIDS or slim disease or what was around. So at least within the medical, with the doctors and the clinical officers over there, AIDS was not a topic we have been discussing. A lot of other topics we discussed, but okay. So I came back. In fourth year of medical school, we had a clinical microbiology course, again, Professor Mazurel teaching. And then, of course, it was known that HIV, or AIDS was caused by HIV, a retrovirus. But at that moment, no medication available, no treatment available. And when you were diagnosed with HIV, this was really, as a patient at that moment, a death sentence. So I moved on. In 1987, I went to do a research elective in Zambia, rural Zambia, for 6 months again. But then at that moment, you saw in the hospital some patients with AIDS, but we really got a lot of questions from people working there, from clinical officers, from laboratory personnel, from nurses, who all had their friends or had a relative being sick with AIDS from HIV, and most of them had been working in the military or in the police or were teachers or had worked in the Copper Belt, which is an industrial area in the northern part of Zambia. Then I came back, did my clinical rotations and started in a small hospital, Bergweg Hospital, which is not there anymore. It's called the Iceland Hospital at the moment, to start my internal medicine medical specialization training. And one of the patients, very early on in my training, which I encountered, was a woman from Portugal who presented with diarrhea, persistent diarrhea. And the gastroenterologist was seeing her at the outpatient department, not knowing what was the cause. And finally, it turned out to be that she was HIV infected, but not HIV-1, but HIV-2 infected. So this was my really first scientific encounter, at least with HIV, as we published this one in the Netherlands Journal of Medicine. So I did my medical specialization training mainly in the peripheral hospitals, secondary hospitals in the neighborhood of Rotterdam, came back for my infectious disease training to this academic medical center. And then at that moment, the people in charge of the infectious disease department and in charge of training me and us as infectious disease residents told me, so we will see AIDS patients, HIV-infected patients, every 4 weeks at the outpatient clinic. They're ill, they will tell you what kind of diseases they would have in the intervening 4 weeks. They will tell you how much weight they've lost. They will tell you how miserable they are, and there's nothing we can do. They will die in the end. And that was the case at that moment. 9 months later, there were the first results of what we call the Delta study, which showed that if you use combination therapy of 2 antiretroviral drugs, people were doing better. But that didn't last for a very long time. 1 year later, in 1996, suddenly we had combination therapy. Suddenly we had HIV drugs in combination, which we then called HART, or which we called CART, combination antiretroviral therapy. And suddenly life changed a lot for the patients, but also for the doctors, because suddenly people were not dying anymore. They were getting well. They had arranged their funerals, but suddenly they could go back to work. And from that moment on until now, a lot has changed, really, mainly in treating and treatment of HIV patients. So I was discussing with Professor Barré-Sinoussi, my outpatient clinic from last Wednesday, where HICS, so the electronic medical record system here, failed. So I had to do without HICS for 1.5 hours. And still, I managed to finish my outpatient clinic in time, because so many patients we're seeing at the moment, at least in the West, at least in this setting, get 1 tablet a day, do fine, have no side effects, have no problems, have a normal immune system, and are undetectable, so virally suppressed. And very often patients come in and you have 50 minutes per patient, and after 5 minutes you don't know what to tell each other anymore, because they have no news, you have no news, you have changed all the information you need, and they very often say, sorry doctor, I don't know anymore to tell you. See you next time, see you in 6 months. So just to show that, for me at least, and I think for many people from my generation, it's really strange to see that in 1981, when I started medical school, HIV was not there. We didn't know about HIV, we didn't perhaps know about AIDS. A couple of years later, there's HIV, there's a new disease, no treatment. 10 years later, no treatment, and suddenly there is treatment and people get better. So it's not a death sentence anymore. It's a chronic disease, specifically in the western part of the world. That there are issues, that there are problems, I think that Professor Barré-Sinoussi will allude to that a lot, but it's just to show you that things change a lot in the generation of a medical doctor, in the life of a medical doctor, as it concerns this disease, but perhaps also other diseases. Rob?
Okay, thank you. Well, it's my honor to introduce Professor Barré-Sinoussi. I will not bother you with everything I can find on the Wikipedia about her. Just to tell you that she is a biochemist by training, and at the time of the discovery of HIV, she was working in France, the Institut Pasteur, in the lab of Professor Sherman. And as Jan pointed out, that by accident he ran into HIV. For me, it was a little different. I was trained in school that retroviruses were oncogenic, so you could get cancer from retroviruses. And with HIV, this whole paradigm changed. This was not it was a retrovirus, but it was not a retrovirus that gave was oncogenic, but was cytolytic, it was killing cells. It was a whole new idea. And I liked that so much that when I started my PhD research, I had to choose between different topics, and I decided to choose for HIV, and I've been on HIV research now for 30 years. And I'm very glad to have learned all this, the complete change of a death sentence to a chronic disease, as Jan pointed out. And I was very inspired by the work of Professor Barré-Sinoussi. I even went to France to work there, because I thought, well, that's where really the discovery was made. And without telling her story, I will give the microphone to Françoise, and thank you very much for coming here.
It? Yes, that's right. Thank you very much for the nice introduction. Good afternoon, everyone. I'm very pleased to be here with you this afternoon. I'm going to, as it was said, during about 1 hour, I'm going to give you some background, let's say, of this history of the discovery of HIV, but I will also very much concentrate on the next challenges that we have to face during the coming years. Of course, during my talk, if you have any question, please do not hesitate to ask me. We will have time also at the end, but please do not hesitate if you have a burning question to stop me and to ask the question. So, if I'm going into... Oh, I made it. So, let's start just to tell you a little bit of my background and why I've been involved in this adventure of HIV and AIDS. It turned out that I started to work at the Pasteur Institute in 1971. I'm not going to give you my age, but you can guess somehow. It turned out that I was at the University of Science in Paris. I should not tell you that because I'm not a good example at all. And I was wondering at the university what I was doing there. I had the idea that I wanted to become a researcher, but going at the university, I could not find out what does that mean to become a researcher. So I decided something that at that time, at least was quite rare. I decided to try to find a lab who will kindly accept to take me as a volunteer, at least part-time, and continue my study at university, and started also to work in a lab. However, what I did, it turned out that working in a lab, it was so exciting that I did not go anymore to university, except for the exam. And I went through the exam, and everything was so clear for me that I made my exam without any problem at all, even if I was not going really regularly to university and I was learning at night or during the weekend by myself. So is how I turned to be at Pasteur in 1971 in a lab working on the relationship between murine retroviruses and cancer. At that time, it was just, as mentioned on this slide, right after the discovery of the reverse transcriptase in 1970. And the lab at Pasteur just in 71 was implementing how to measure reverse transcriptase activity in the cell culture, mouse cell culture. And they asked me for my PhD to start to work on a drug which was shown to increase the survival of mouse when infected by friend leukemia virus, and to find out whether this drug was an inhibitor of the reverse transcriptase. So it's how I really started in 71. And after my PhD at Pasteur, indeed, the data showing in the United States that cancer was related to oncogene, and that the oncogene who was present in retroviruses were indeed originally cellular oncogene. Most of the teams stopped to work on retroviruses, except very few teams, except the team of Jean-Claude Sherman, where I was, decided to continue to work on retroviruses and cancer. And he said to me after my PhD, you have to go to US for your postdoc, and the best is to go to the NIH. And at the NIH, I started to work on genetic restriction of murine leukemia virus, which was the FV1 restriction. I'm telling you that because you can find out immediately on this slide several links with HIV somehow. And when I came back from my postdoc, I started to work on the control of endogenous retroviruses in mouse by type 1 interferon. By type 1 interferon, but I started also to collaborate with another researcher in the lab who was very interested in the relationship between mouse mammary tumor viruses, at least the presence of MMTV sequences in a lymphocyte of women who were presenting breast cancer, lymphocyte. So that means that at that time, we knew how to, we started to know how to grow lymphocyte, T lymphocyte in the lab. We knew how to measure the reverse transcriptase, of course, activity. We were interested in control regulation of retroviruses in cells, including genetic regulation in the mouse, and also including regulation also by type 1 interferon. So it's where we were when in 1982 HIV/AIDS was recognized in my country, in France, in the hospital by a clinician. After the report in the United States of this new alarming emerging epidemic reported by Michael Gottlieb originally. I'm showing you this slide because I think that has been impacting all the story of HIV/AIDS. It turned out that the disease that you know probably has been recognized in homosexual. You can see on the slide that in several journals they were calling it the gay plague. And of course, it was a kind of hysteria, I must say, in the early 80s in the world. Those young guys were dying in terrible conditions. It was really a drama. And in addition, to tell you the reality, for example, after we identified the virus at Pasteur, it was written in the newspaper, the French discovered the virus of homosexuality. So I'm telling you that because at the start of a story like that, when you have discrimination against population, it can remain almost forever. And still today, we still have a lot of stigmatization and discrimination against key affected populations by HIV. This is, we have to be careful about this kind of situation. The second message I like to give on this slide is that the virologists like me, we are not obviously informed about disease which are seen in the hospital. So we are really mobilized ourselves by epidemiologists, by clinicians, who are the ones who are the first observing the emergence of disease. It's exactly what happened for us. Willy Rosenbaum, one French clinician, together with Françoise Barré-Sinoussi and Christine Rouziou, they came to us at Pasteur. They came to us at Pasteur because they were belonging to a working group already taking care of people affected by this new emerging disease. And they were asking to themselves the question, what can be the etiological agent? And they were asking a very simple question. Most of the viruses that are known has been mentioned as potential etiological agent for this new emerging disease. None is corresponding to the right agent. They were informed about the identification in United States of HTLV1, the first human retroviruses affecting T lymphocytes. So they came to us because they were students at Pasteur in the past, and they remember that we were giving the course on retroviruses, and they asked a very simple question, do you think HTLV1 can be the cause of this disease? It's how the story starts. And we told them we don't believe in HTLV as a cause of AIDS. We did not know too much about AIDS, I must say. They explained to us the symptoms, they explained to us all the observations known at that time. And this meeting was really a very decisive meeting with them. And we start to ask very simple question: when to look, where to look, how to look, for which virus. That means that we did not start with any dogma, any possibility that it will be HTLV, for example, for sure. We say, okay, let's try by a very conventional, classical approach. Let's try to put in culture a sample. But which sample? So it was really with talking with them that we decided to take a lymph node biopsy from a patient who was not yet presenting with AIDS. And that was, I think, a very important decision. Because, of course, we said to ourselves, I mean, if we are taking a patient with AIDS at the late stage of the disease, there is no more CD4 lymphocytes, so it's not the best time to try to isolate a virus from a patient who do not have any more CD4 lymphocytes. So it's Willy Rosenbaum said to us, but they have generalized lymphadenopathy early on. So, and we asked, can we have a sample of lymph node? And say, oh, I think there is a patient, Brew, who will be very, very collaborative. And he asked the guy, and the guy kindly said, yes, I accept to have a biopsy. The biopsy arrived at Pasteur in January 1983. My lab book is here on the slide. We put in culture in January, and few weeks after, you can see here, really started to be more significant. At the beginning of February, we could see a reverse transcriptase activity in the supernatant of the lymphocyte of Brew that were in culture. So that was the first sign, of course, of a virus in the culture. You can see here what we observe after the beginning of the culture. We saw a peak, really, of the reverse transcriptase activity at the end of January. But we can see on this line on the curve a decrease of the reverse transcriptase activity, and we observe at that time the cell death. It was a little bit of panic, I must say, in the lab, because we said, okay, maybe we have the virus causing this disease, but we are losing the virus because the cells are dying. Fortunately, at that time at Pasteur, we had a blood bank. We don't have a blood bank anymore. We cross the street and ask whether we can have a sample from a blood donor, isolate the lymphocyte, and put immediately the lymphocyte into the culture. Immediately, we saw exactly the same phenomenon. Reverse transcriptase activity and a decrease in reverse transcriptase activity and cell death again. We say, that's it. This is really related to the multiplication of the virus. And we asked the electron microscopist, Charlie Doguet, to look at the cells, and Charlie started to tell us, I can see some particle, I can see some budding, I can see particles that the size of the particle is exactly the size of retroviruses. And, but it's a little bit funny because the core is not central as it is for HTLV1 or oncogenetic viruses. The core is not central at all. But clearly there is budding particle in your culture. We found also that the reverse transcriptase activity was associated to RNA, and that the density in sucrose gradient was exactly corresponding to the density of retrovirus particle. So it is more or less, I have to go back. How I go back? No. Yes. What we reported in the publication of Science in May 1983, we also mentioned that we were able to propagate the virus on peripheral mononuclear cells from blood donor. The reverse transcriptase of this virus was working in conditions similar to HTLV. However, we received a sample from Bob Gallo's lab and from HTLV reagent. And HTLV reagent were showing no cross-reactivity at all with the virus we isolated, in particular for the P24 protein or P19 protein of HTLV1, no cross-reaction at all with the protein of the virus. We reported also in that paper that a patient with AIDS was presenting antibody to the virus that we isolate, like our own patient have antibody against the virus we isolate. So that was really the very beginning of the story. That was not enough at all to convince that the virus was the cause of AIDS. In order to convince both the scientific community but also the decision makers that this virus was a cause of AIDS, we had to isolate the virus or an identical virus from other patients, of course. We had to make the link really between the virus and the disease itself by making virus isolation, but also by making seroepidemiological studies showing that only people that were affected by AIDS or AIDS-related symptoms were presenting antibody to the virus, but not the others, and so on. We had, at the same time, to start to characterize this virus that we call originally lymphadenopathy-associated virus, LAV, because until we had proof that the virus was really the cause of AIDS. So the virus characterization, that means that we had to characterize the genome of this virus, the protein of this virus, the tropism of this virus from different cell subpopulation, and that also it was a tremendous amount of work for a small team. Originally, we were 3 persons to work on that. So I must say that first decision that we had to take in the lab to stop all the other programs that we were working on. It's not an easy decision, but we did it. Secondly, we decided to mobilize others to mobilize other clinicians, to mobilize other researchers, other virologists, other immunologists, biochemists, molecular biologists, and so on. Next, we say, okay, but if we want to make a seroepidemiological study, we also need to develop tests anyway for the diagnosis, because we knew already from the epidemiologists that, unfortunately, people, hemophiliac, were affected by this disease. So we knew that the virus could be transmitted by blood and blood derivative. So we knew that it was an emergency in terms of developing serological tests for diagnosis. So we had to mobilize also the private sector, and we started to work together with the private sector immediately in 1984. To produce the virus in large amounts. And that was for me, I mean, the first time in my life to work directly with the private sector in the lab, in the lab at Pasteur in Paris. It was the first time also for me as a PhD to have patients coming to us at Pasteur. Not to see a doctor because they knew that I was not a doctor, but to ask us very simple question, very important question for them. What are you going to do with this virus? Can you explain to us what is this virus? What is the next step? When do you will have a treatment and so on? So it was a lot of pressure, I must say, that we had even as a researcher and a new experience. So for the diagnostic test, one of the first priority, we worked together with Françoise Barré-Sinoussi, Christine Rouziou, and others to develop ELISA tests. We were producing liters and liters of virus, I must say, directly in the lab. We purified the virus originally, and the first ELISA were from purified virus, so a mixture of virus particle with all the viral antigens for the first generation ELISA. At the same time, we started also to make first generation Western blot as confirmatory tests. And since, of course, then everything has changed a lot. Everything has changed a lot since we have now new generation of tests based on recombinant proteins and peptide. There are several ELISA tests that has been commercialized also for confirmation, but now we have also in our hands community testing, self-testing, and all the tests has been validated, and they are very, very specific and very sensitive, which was not the case at the very beginning when we started to prepare the first generation test, and when it was even commercialized by Sanofi Diagnostic Pasteur in July 1985, that were not the test, that the quality of the test that we have today. Anyway, we needed to have a preliminary test for avoiding infection. From the data we obtained also on the virus, it has been developed a little bit later on, other tools for diagnosis and for monitoring based on our knowledge on the genome of the virus itself. The molecular tools, of course, based on using PCR to quantify the virus, and including now these days, we have some generic tests for quantifying HIV in the lab, which might be very useful in resource-limited setting. So, derived from the work on the characterization of the virus, the development of these molecular tools, also for later on detection of resistance to antiretroviral treatment. Cloning and sequencing was one of the first steps to be done. The first complete sequence of the virus was obtained early 1985, and we understood from the sequencing of this virus that it was a very complex genome, very distinct from HTLV1. We were quite fast, I must say, in characterization of this genome. Probably you took almost, let's say, 1 year and a half. Today it will be very rapid. But I used to ask the student how you do to clone and sequence virus when you don't have PCR. Was our situation at that time. PCR was not yet available. So, of course, now we have high throughput sequencing, we have all of this, but at that time we did not have all of that. So we had to make a probe by reverse transcriptase to copy a small fragment of the viral RNA in order to use this fragment as a probe to screen a DNA library prepared from lymphocytes infected by the virus. So it's how we start to make the sequencing on a fragment of DNA to put all the fragments of the sequence together and get the data on the sequence that was done with Simon Wenopson, Pierre Sonigo, and Mark Allison. And it's how we obtained this sequence. In particular, we found out that it was gene that was not represented in other viruses, in particular the regulatory gene that you can find here, V, VPR, VPU, NEF, in particular, that you have on this slide. And we have seen that there is it was an homology between the sequence of this virus and Visna, lentivirus found in the past in sheep. And we started also to study the diversity of this virus and found out very rapidly, because Bruno Smear, as soon at the end of 1984, has some data indicating that when you compare the virus from one patient to the virus to another patient, the virus was a little bit different. That was the start of a story of the diversity of HIV-1. Since then, since then, it has been a lot of study on the diversity of HIV all over the world. We learned that we had a different group of different type, different group, different subtype of HIV-1. You probably know that the major virus causing the epidemic is what we call HIV-1M. We know that the group HIV-1M contain many subtype and recombinant viruses that are shown on this slide. We learned that we had other group that has been detected in Africa, like the group O or the group N, which has been reported in Cameroon. You were mentioning Cameroon. For HIV-2, it's also represented, as shown here, by several groups. And the diversity of this virus is enormous, and we learn also from work from Simon and many others that when you look at the virus in one individual, nobody is infected by one virus, but by subspecies of HIV-1, and there is an evolution during the infection. After exposure to the virus, you can detect the virus. We call it the founder virus, and then you can see the evolution of this virus in one individual. It has been a lot of study also on the origin of the virus, and we know today that HIV-1 is a zoonotic infection, like many others. We suspected strongly after the identification of HIV-2 and the relationship between HIV-2 and Sooty-Mangabe in West Africa. Indeed, when you compare Sooty-Mangabe virus isolate from Sooty-Mangabe and the virus from someone infected by HIV-2, if you don't know the origin, you cannot know if it is a monkey or human, so they are really very close. So we were suspecting for HIV-2, we know now that it has been about 8 introduction of virus from Sooty-Mangabe to human. Regarding HIV-1 derived clearly from chimpanzee and gorilla, as mentioned on this slide. 2 viruses derived from gorilla and 2 groups derived from chimpanzee. Originally, as I mentioned before, the virus from chimpanzee was found in Gabon. However, when we isolate the virus in collaboration with our colleague in Cameroon, we isolate HIV-1N. We found out that HIV-1N was close from the chimpanzee virus in the same country. Next also was to, as I said, to characterize the tropism of the virus. That was done quite rapidly with David Klatzmann and Jean-Claude Gluckman. We found out that the virus was infecting preferentially the CD4 lymphocyte. And we could isolate the virus from infected individual from their CD4 lymphocyte, not from CD8 cells. So that was all the beginning of the story regarding the tropism of HIV-1 for CD4 lymphocyte. We also reported that in culture, it was clearly a cytopathic effect of the virus that was corresponding to the cell death that I mentioned before. You can see here the bubble when the culture is infected by HIV and the cells are dying. However, this is seen in vitro. It's not so clear in vivo, the cytopathic effect of this virus. Rapidly with David also, we identified the main receptor of HIV-1, the CD4 molecule, and that was published already in 1984, as mentioned on this slide. We started as well to characterize the reverse transcriptase of this virus with the idea already, that was already in 1984, the idea that reverse transcriptase could be a target for treatment. So that was done with Dominique Dormont, and since I mentioned before, I made my thesis on a drug, HPA23, who was a reverse transcriptase inhibitor, and that drug has been tried before in a phase 1 study by Dominique Dormont for Creutzfeldt-Jakob disease, since it was nothing at all for HIV/AIDS patients. We have been allowed at that time to test this HPA23 in 3 patients with AIDS and 1 patient with pre-AIDS symptoms. Unfortunately, the drug did not work at all in AIDS, And soon after, the data with AZT were published. And of course, everybody moved to other antiretroviral molecules. So this is the beginning of a story, as it was said earlier. Before, let's say, 96, it was really a tragedy. A tragedy first for the patients, a tragedy for the doctors and for the medical staff, a tragedy even for us, the scientists, as I said, because we were for the first time in contact with people who were dying, and some of them became our friends, by the way, and died. So until we had the wonderful data in 1996 of combined antiretroviral treatment, combined reverse transcriptase inhibitor together with protease inhibitor. That was the key. That was showing for the first time a control of the replication of the virus, as shown here, and the immune function were also restored in the patients. And we know now that indeed not only this treatment is preventing AIDS, but is improving the quality of life, it prolongs the life expectancy, and we learn that this treatment is also preventing transmission. So all of this is based on our knowledge also of the replication cycle of the virus, which is shown here on this slide, with several molecules which has been developed. We have more than 30 antiretroviral molecules today that has been approved by the FDA. They all target different steps of the replication cycle of the virus, either the entry, I cannot see either the entry of the virus, or the reverse transcriptase or protease inhibitor, as I mentioned. We have now also inhibitors of protease, and this treatment has been, of course, a lot simplified since the first treatment in 1996. Here are all the different treatments approved by the FDA, the reverse transcriptase inhibitor, nucleotide, non-nucleotide reverse transcriptase inhibitors, the protease inhibitor, fusion inhibitor, integrase inhibitor, and multi-class combination that has been developed since then. The drugs are really now also useful for prevention. This slide is mentioning in black, I mean on your left, all the tools that can be used for prevention, but the classical tools, the condom, education, behavioral intervention, harm reduction program, etc. But on the green, on the left, you can see all the new tools that we have today, including antiretroviral treatment for prevention, either including antiretroviral treatment, for example, in vaginal rings for women, using more recently, you probably heard about oral pre-exposure prophylaxis, the PrEP. The PrEP that can be used for the gay population to prevent themselves from infection, and we know that if they use it really correctly, we know that PrEP can prevent more than 90% of the infection. PrEP is not used everywhere yet, unfortunately. I'm happy to say that I'm in a country where the Ministry of Health decided to make PrEP available for free for people, and this is was a great decision. We have also, of course, antiretroviral treatment for post-exposure prophylaxis. And we know that really using antiretroviral treatment for prevention is working from 0 to 90, almost 99% if it is used correctly. The future will be probably the long-lasting drug, antiretroviral drug, which are in the pipeline. Now there are encouraging data with drugs that can be used and are working for a long time. So this slide, and I will go very shortly on this slide, it cannot summarize everything, of course, of 35 years of HIV science. I'm showing it to say that HIV science is really, in my opinion, a very good example of what we call today translational science. We started by the identification of the virus, and of course, we started by basic science, which is summarized in blue on this slide, but with the idea to develop as fast as possible tools for diagnostic, tools for monitoring, tools for treatment, and tools for prevention. So you can see the green is treatment, and you can see that the green is following really the blue, so it's really derived from our knowledge, our basic knowledge. Prevention is in pink on this slide, and of course we don't have a vaccine today, but you can see that we have already developed several tools for prevention. I like to remind people that finally we knew as soon as 1994 that antiretroviral treatment is already prevention by the report of AZT, this antiretroviral treatment, and a reverse transcriptase inhibitor, was capable to prevent mother-to-child transmission of HIV-1. So that was really the first evidence that antiretroviral drug can prevent HIV infection. Next message on this slide, you see the blue coming back. Because if we want to move on and have new tools responding to the need for the people affected by this disease, those tools will derive again from basic science. So, another message I like to give you is, for me, of course, I've been involved in the identification and the discovery of HIV, but it's something else that I've discovered because of HIV. I found out what was going on in a resource-limited setting. I had the chance, I say the chance today, to be called in 1985 to participate to a WHO meeting in Central African Republic. For participating to a group trying to define AIDS in Africa, 1985, together with Jonathan Mann and others. And myself and many others who were there really realized what was going on in Africa. You were mentioning that in Cameroon you did not see any HIV/AIDS case at that time in rural area. I can tell you that in Bangui in 1985 we went to the hospital and it was unbelievable that people were dying there from AIDS, and nobody recognized that they were with AIDS before. So the situation was really dramatic, and it's certainly at that time that I realized, and many others realized, that we have to work together with people in Africa. Later on, I was called in Vietnam and started to work in Vietnam before indeed HIV was recognized in the region because the first case of HIV in Vietnam was 1991, and I started to work with them in 1988. So my message here, I was working at Pasteur since 71. I knew about Pasteur vision, and I knew that Louis Pasteur implemented institute in Vietnam after Paris. That was the first one after Paris, and started to implement many Pasteur institutes in Africa and Southeast Asia and so on. But I did not realize really what was his vision. And I said, my God, that guy has a wonderful vision at his time, that we have to work with those countries, and reminded me what he said, that science knows no country because knowledge belongs to humanities and is a torch which illuminates the world. Of course, he has the humanist vision and the vision of translational research for all the people affected by a disease. So I realized myself by working with this country, and I think that a lot of people working on HIV/AIDS have realized at that time that the role of us scientists working in the field is really to provide scientific evidence by making multidisciplinary science research. We provide the scientific evidence, and the scientific evidence should be given to political leaders and health authorities in the countries in order for them to decide to implement intervention, to organize the intervention in order to take care and to make access to treatment when the treatment is available. This, I realize, and we, several of us realize, that will not be possible without strong interaction with politicians, without also interaction together with representative of patients. We started, and I think HIV/AIDS has been really the first disease for which it has been a so strong interaction with activists and scientists and doctors. By working together in countries, it's certainly how we can make pressure on the political leaders. I have a slide here showing Pauline Londex, one of former representative of ACT UP, speaking with Nelson Mandela. And here you can see Joep Lange in Paris, trying to convince the politicians that we need money for people living with HIV. So it's together with training, strengthening capacity and structure in the countries, we can move on and bring some benefit for the people affected by a disease like HIV. Of course, it's through the movement of our colleagues, the activists, and working together with them that we certainly have convinced the political leaders to bring money to make the treatment available for all. You can see on this slide that in 2001, it was almost no money available for access to antiretroviral drug, to access to treatment. But you can see that since 2001 to all over the year, it has been a lot of increase of funding available, like the funding by the Global Fund, by PEPFAR, investment, for access to antiretroviral drug in low and middle income countries. And it's because of this access to antiretroviral drug, because of this pressure of the activists, that we have seen also the price of the drug decreasing all over the time. You can see on this slide, I will just mention shortly the combination of tenofovir, 3TC, and efavirenz. You can see that today it's about $100 US per year for treating patients. Of course, it's a first-line treatment, and of course, still the second-line treatment and third-line treatment is too expensive, in particular third-line treatment for the developing world. But there is a lot of progress since all this movement have been made. As a result, we have a global scale-up of the HIV treatment as a result of this global investment, the reduction of price, the development of generic, and the development of new delivery service in the countries. You can see that today we have 19.5 million of people on treatment in the world. We know that this treatment, as you said before, it's really unbelievable. Today, we can say that it is illustrated on this slide that if someone is infected by HIV at 20 years old, if he is treated, his life expectancy is almost the same, plus 55 years compared to someone who is not infected by HIV. We know also that if we expand the treatment, even in developing countries like South Africa, which has been strongly affected, as you probably heard, by HIV infection, you can see a decrease, progressively decrease, of the incidence of the infection in a country like South Africa. Overall, during the years, since the access to antiretroviral treatment increased in the world, this slide showed that we have seen that a decrease since 2005, about 50% decrease of the mortality, of the deaths by AIDS. The percentage of new infection, there is also a decrease since 2005 that you can see on this slide, but still the reduction is about 30%, which is not sufficient, really. That means that we have to continue all the effort. We have to continue the effort because today we have almost 37 million of people living with HIV in the world. I remind you that about 35 million of people already died for AIDS. Last year, 2016, we had 1.8 million of new infections in the world, so it's far to be over. And we had 1 million of people last year who died from AIDS still. So the problem is still there, despite all the progress. We have many challenges to face. The first one is certainly to prevent new infection, to prevent those 1.8 million of new infection through education programs, through condoms, or circumcision, risk reduction, using antiretroviral treatment for prevention. We need to improve the testing, the treatment, and to maintain people an antiretroviral treatment. We know that in the world, depending on the country, we have between 30 to 50% of people who are infected and they do not know that they are infected by HIV. That means that they continue to transmit to others. We know also that on long term, if we look the continuum of care of people who are on antiretroviral treatment, we have only 25 to 60% of them who show viral suppression on long term. That means that there is a significant proportion of people who are not adherent to treatment for many reasons. So that means that we still have to strengthen the health system and services in the countries. We need to have a leadership really in the countries where they need to have national integrated policies. We need also to improve, to optimize the continuum of care with care package, early test and treat, point of care, long-acting drugs that I mentioned will be a solution. We need to improve also the community access to antiretroviral treatment. The community may be involved in delivery, in supporting patients. We need also, and there is a full development of digital health today in order to improve also the access to antiretroviral treatment and the maintenance to treatment. This will not be possible without political willingness, without international investment that should continue. And we need for disease like this one to continue, as I said at the beginning, to fight against stigma and discrimination. You know that in the world we have more than 70 countries who have repressive measures against people strongly affected by HIV or hepatitis or other infection. This is really not acceptable. Those people should have access to care like any others. So, of course, to try to improve the situation, WHO and UNAIDS decided to have new objectives, which are summarized on this slide. A very ambitious objective, 90% target. 90% of people to be aware of their serological status. Today we have 69.5% globally who are aware about their HIV status. Those people who knows their HIV status, today we have only 53% of them who are on antiretroviral treatment. We want 90% of them to be on antiretroviral treatment, and we want 90% of them to have a virus replication suppressed on long term. This is very ambitious, but as I was mentioning before, we need to have very ambitious goal in order to try to be as close as possible to this goal. Whether that will be possible, achievable, sustainable, we don't know yet, but we have to try. We have to try knowing also that probably if we are successful, we will be able to control the HIV epidemic by using all the tools that we have been developed and showing the evidence that those tools are efficient. However, we know that if we want to eliminate really HIV, that will not be possible without a vaccine or without a cure. So that means that the challenges that we have today is still to develop a vaccine. We are making progress, but even if we still do not have a vaccine, we need to discover a cure. We know that the virus is persistent even on antiretroviral treatment. And in the middle of this slide, I put another priority, which is the comorbidity and long-term antiretroviral treatment. We know that there is the vast majority of patients on antiretroviral treatment are doing well, but there is a small proportion of them who are developing what we call the non-AIDS-related mortalities. They are developing cancer, they are developing metabolic disease, cardiovascular disease, they are developing, for some of them, neurological disorders. And of course, I put them all the priority on the same side because for me, I think there is a link regarding those different priorities. We need for both of them a better knowledge on basic science, on latency, immunology, and pathogenesis in order to develop new vaccine, new therapeutic strategy. And if we have a new therapeutic strategy, I'm sure that we will solve also the problem of the comorbidity on antiretroviral treatment. So, vaccine, I will go shortly. Vaccine, over than 200 trials done in the world, but only few efficacy vaccine done. This slide summarizes some of them. Indeed, none of the efficacy trial up to now have worked, except the modest reduction of HIV infection shown by the Thai trial RV144, from which we have learned since then. And most of the vaccine trials used now are based on prime boost after this vaccine trial, coming from with the first vaccine candidate and making a boost with the second vaccine candidate. And we learned also that from these studies that type-specific binding antibodies might be important. CD4 response might be also important, and also probably, by the way, ADCC response might be important. So since 2009, the field is moving. The field is moving also with the identification of very, very potent antibody, broadly neutralizing antibody, originally isolated from patients called elite neutralizers, a very small percentage of people. Those antibodies, the structure of the antibody has been characterized, functionally characterized, and derived from the structure. The scientists have been able to reconstruct those broadly neutralizing antibody, and several antibodies has been obtained, and some of them are advanced in clinics, as shown on this slide. We have learned also that non-neutralizing antibody may have some protective function through ADCC, for example. So the field is moving to a structure-based immunogen design with novel delivery system. And also we know that in addition to antibody, we certainly need also to improve T-cell response by, for example, making genetic engineering and gene transfer in T-cells, using finally gene therapy somehow. DC targeting is also another approach that some researchers are using for developing a vaccine. Oops. So we are in a new era. There is considerable energy in HIV vaccine field since the Thai trial in 2009. Several prime boost strategy ongoing. I mentioned on this slide two of them from which the data should come soon. The P5 trials, the PROX protein public-private partnership, using adenovirus also, or MVA, for example, plus trimer glycoprotein. There is a lot of concept, test of concept studies using, in particular, neutralizing and non-neutralizing antibody approach. But for the first time, shortly, what I like to say in the field of HIV vaccine, we have a strategy today that integrates really basic and clinical studies all together, and we have enhanced new technologies that we did not have in the field in the past, and I'm sure that we will have a new concept in the field of vaccine discovery coming through in the coming year. Vaccine, by the way, will be certainly used also for cure. So it's a reason that we cannot separate cure research for vaccine research. Cure research, very often people ask me, why are you have been pushing so much HIV cure research? I say, don't ask myself as the patient. Because it's what I did personally, going in Africa, going in Southeast Asia, seeing people doing very well on antiretroviral treatment. I'm asking, what are you expecting from us, a scientist? You are doing well. I say, can we have a treatment we can stop? So, I mean, if they say that, that means that we have to move on and try to develop a treatment. There is plenty of questions in the field of HIV cure that need to be solved. And for that, we don't need only biomedical research. We need also social and ethical science. We are not in the same situation that we were before 1996. We have patients that are doing well on antiretroviral treatment. So we need to understand better what the patients are ready to accept or not to be part of new clinical trials. How we can best engage them in clinical research. We need also really to prepare carefully with them, with patient representative, any of the studies that has to be made in the field of HIV cure. We need also to have a cure because, as I said, we have only 53% of people today who are on antiretroviral treatment. Another question which is raised very often by the patients themselves, they say that even if they are doing well on treatment, they still feel stigma and discrimination on treatment, and they feel that if there is a cure, it will be a relief for them. From those aspects. International investment on long term, it's a real problem in the world. So we know that lifelong antiretroviral treatment is unlikely to be sustainable and long term. What kind of cure are we looking for? Generally, when we speak about cures, that means that we should be able to eliminate all the virus from the body, from the different compartments of the body. I used to say this is almost impossible mission with a virus like HIV. We have only one proof of concept with a Berlin patient who is HIV positive, was treated on antiretroviral treatment, developed leukemia, and was receiving a bone marrow transplant from a donor who was a mutation in the receptor CCR5. Today, the Berlin patients still remain with undetectable virus. But all the attempt to repeat the Berlin patient up to now did not succeed. We think that we should be able to have remission. Remission, that means to have a treatment which will be able to reduce the virus and for the patient to be able to control their virus after they stop the treatment. In addition, since the virus will be controlled, they will not transmit the virus to us. And we have proof of concept for that. We have the Mississippi baby. I am summarizing on this slide different situations. We know that in patients who are on ART, if they stop their treatment, we have a viral rebound generally at 2 or 4 weeks after they stop the treatment. But in the Mississippi baby, the baby was treated at birth, the mother stopped the treatment, and 28 months after she stopped the treatment, it was a rebound. So a delay in the viral rebound. And we have now the cohort of what we call the Visconti patients, patients that were treated very early on during the primary infection within 10 weeks after exposure of the virus by antiretroviral treatment, and they stop the treatment after 3 years in agreement with their doctors, and they found out that now it's more than 12 years that they stopped the treatment and they are still perfectly controlled. So the Visconti are the proof of concept that by treating very early on, you can have a control, a persistent control. You can have a remission, a durable remission, sustainable remission. What can we do to try to induce, such a situation? That is the main question today, if I can find out. Yeah. So this is the reason, based on those observations, we thought it was time to try to accelerate and try to develop novel strategy. And it was what we decided to do at the International AIDS Society in 2011, trying to mobilize the funder, mobilize the scientists to work together more efficiently in order to make more rapid progress, let's say, in the field of HIV cure. So there are many challenges. The first challenge is we know today that if the patients are on treatment, the virus rebound, and the virus rebound because there is reservoir. And we learn a lot about the reservoir cells. They are summarized on this slide. The major reservoir cells are quiescent cells, resting central and transitional CD4 plus memory T cells. We know that those cells are persistent and stable on antiretroviral treatment for more than 10 years. There are other reservoir cells which are listed rapidly on this slide. Naive T cell, memory stem cell, T follicular helper cells, those cells that we found in the lymph node, are today clearly shown as very important reservoir cells for HIV. Myeloid cells are reservoir as well, astrocyte, hematopoietic progenitor cells, and so on. So you see a large list of cells that serve as reservoir that remain on antiretroviral treatment in different compartments of the body. Those cells are not present only in the blood, they are present in all the lymphoid tissues, they are present in the gut, they are present in the genital tract, they are present in the central nervous system for some of them. So you start to understand why it's going to be so difficult to eliminate all those reservoir cells. And we know that those cells remain there because even an antiretroviral treatment, at least in some compartments, there is a low level of replication of virus that remain, and allowing the extension and the propagation of the reservoir cells. We know that those reservoir cells are surviving, but we know also that they proliferate, and they proliferate with a clonal expansion of cells that remind us the proliferation of cancer cells. Indeed, we learned during the last years that those cells that serve as reservoir are expressing molecules that we can find on tumor cells, like PD-1 molecule, like CTLA-4 molecule, like LAG3 or TIGIT, all the molecules that we found on tumor cells. So there is some analogy between reservoir cells, latent infection of the cells, and tumor cells that to take into consideration for the future. We know that the reservoir also is established very early on after exposure to the virus. Indeed, there are several studies, including that one, that show that within 3 days after exposure to the virus, there is an establishment and a beginning of propagation of the reservoir in vivo. And we learn all over the years that there is a link between the expansion of the reservoir, the propagation of the reservoir, and the level of inflammation, immune activation that remain at low level even on antiretroviral treatment. So clearly, chronic inflammation that remain on antiretroviral treatment is clearly one driver of HIV persistence, but also is probably one driver of non-AIDS mortality in HIV-infected patients. We know since years that HIV infection is inducing chronic inflammation. There is a link between chronic inflammation and expression of immune checkpoint molecules that I just mentioned, exhaustion of regenerative capacity, immunosenescence, and lymphoid tissue damage. But we learn also that on heart, we have a residual level of chronic inflammation, which is related also to HIV persistence. And we know that the inflammation is also related to cardiovascular disease, cancer, osteoporosis, neurological disorders. And probably there is a relationship with non-AIDS mortality. So the reason before I was saying that we cannot separate research on HIV cure to those aspects of non-AIDS mortality and trying to avoid them. What are the opportunities? I will go very shortly. The first opportunity is certainly to try to reactivate the virus which is latent in the reservoir cells. And we know how to do that by, for example, molecules that can modify the chromatin or the epigenetic mechanism. And there are several studies that have been done trying to use, for example, histone deacetylase inhibitors like vorinostat, paranostat, romidepsin, or also molecules that are playing a role on AKT activation or PKC agonist. And the studies that have been made up to now show clearly an increase of expression of HIV RNA, indicating that there is a reactivation of virus. However, when we look on HIV DNA, you can see on this slide that none of the treatment used here show a reduction of HIV proviral DNA, indicating that the treatment alone to reactivate is not working. So the other idea is, of course, that the scientists ask, of course, it's not to reactivate, but if we don't eliminate immediately the cells that are reactivated, then it will be an expansion again of the viral reservoir. So let's try to combine the strategy of shock to combine it to kill in order to enhance immune mediated killing or enhance apoptosis of the cells in order to eliminate the cells after reactivation immediately. And there are several ongoing studies that combine latency reactivating agents with immune-based therapy. Up to now, none of them has been shown very efficient. However, I like to mention here the study done by a group and published last year, showing that if you use HIV vaccination plus TLR7 agonist, you can have a reduction of the virus, a better control of the virus, as shown here on this slide, compared to the vaccine alone, if you use or TLR7 alone. So there are data that are, of course, very, very preliminary today, but encouraging. Another approach which is interesting is to use bispecific antibodies binding to HIV and binding to CD3, CD8 molecules in order to try to reduce, to try to have killing of cells that express HIV immediately after reactivation of the cells. And you can see, at least in vitro, you have interesting data showing here a decrease. Which strategy for reducing inflammation. There are several strategies which are unstudied today. Trying to use cytokine, IL-21, IL-15, for example, trying to reduce the proliferation induced by inflammatory context, trying to induce interferon pathway, or trying to use molecules that are targeting the JAK-STAT, for example, pathway. And finally, I like also to mention the fact that we are thinking about using very similar strategy as the one in cancer today, in particular by using blockers of the immune checkpoint. You know that immune checkpoint are showing very interesting data in cancer. And we know, as I mentioned before, that the cells that are a reservoir are expressing this immune checkpoint molecule. So there are several studies which are mentioned in this slide going on in United States and in a few countries, other countries, Australia, Germany, Denmark, etc., and even in my country, in France, in order to try to study in patients which have antiretroviral therapy but develop, unfortunately, cancer and need cancer treatment by anti-PD-1, anti-CTLA-4 or PD-1 ligand, to see what will be the impact of this treatment of the reservoir, in particular on the immune response, on inflammation. So there are several studies going on in different countries in the world. Finally, I will finish by another potential strategy is to try to make the cells resistant to HIV-1, like it was the case for the Berlin patient by using a donor with a mutation in CCR5, or to try to excise the virus from the reservoir. This is the approach of gene therapy, of course. Gene therapy is a very interesting approach. Up to now, there are data that are giving some interesting data. Most of the data are, however, in vitro. To excise the molecule, we can act the CRISPR approach in order to try to excise the virus from the reservoir cells. We can think also to improve the response, the immune response, by modifying the chimeric antigen receptor, by modifying the TCR as well. So the gene therapy is certainly interesting. I used to say that probably we are going to learn a lot from gene therapy. It's the question is whether this can be safe, affordable for all the countries in the world. That is another question. So where we are going today, I will say that we need to minimize the size of the reservoir, either by limiting the formation of this reservoir, by early treatment, or also by using, why not, broadly neutralizing antibody. We may have to choke, that means to reactivate the latently infected cells using different molecules. Probably we don't have the best molecule today. We certainly have to kill the cells that are reactivated, either by using vaccine therapy or by using anti-PD-1 or PD-1 ligand. Or broadly neutralizing antibody, trying to have ADCC also. We can think about gene therapy, as I mentioned. Probably we will go to a combination of both in the future. But we have to keep in mind that we have an urgent need today, is that we do not have the best biomarker to quantify the reservoir, is what the study on the Mississippi baby, for example, told us. We thought that the baby was totally negative and eradicate the virus, and then she rebound. So that means that we do not have the best marker. A new marker has been reported this year, CD32A, reported by Monsef Benkeram as a marker which apparently is expressed in higher level on reservoir cell. And we think about going certainly to a personalized cure therapy in the future, keeping in mind that we need affordable and scalable strategy. We'll move on this slide rapidly to say that HIV cure intervention should be cost effective, and it will be, according to some studies, if it is less than $100 and $400 US. Finally, and I will end on this, for HIV cure, since the very beginning, we had a multidisciplinary, integrated, and coordinated strategy. We should continue for cure. We should continue to integrate basic science, clinical science, social science all together if we want to move on for the next challenge that we have to face today. We need certainly to involve other disciplines. I mentioned cancer. For the first time this year, we organized a forum in France before the AIDS conference, the IAS conference this year, mixing together researchers in cancer and researchers in the field of HIV cure in order to benefit from the experience of each other. We need to involve the private sector and work also with the private sector. And of course, we need to involve all the funding agencies to better coordinate their effort all together, is what we are trying to do in that area. I will finish to say that HIV cure has been really integrating all the components of research in order to move as fast as possible for the benefits of patients. The reason that it is a global health concept that has been used for the field of HIV/AIDS. I'm sure that by using this kind of approach, we can move on and make progress for many other diseases, infectious disease, but also non-communicable disease, and reminding people that investing in science is also investing in global health. Thank you very much for your attention.